less people dying.
I think so. I think that, for example, there's some new things we're looking at the biopsy tissue itself to decide whether this tumor that's even more accurate than just saying it's a Gleason 6 or a Gleason 7, to say, okay, this really does have potential to shorten this person's life. Let's recommend surgery or radiation. Or this really does not have the potential to impact this person's life. I think we can safely watch this. So there are some things that are going to help out with that. And then I think there will be some other tests that are more accurate than PSA. They're sort of, like I say, in the pipeline that will help us a little bit more.
What you're really saying is that in the future, and probably not in the too distant future, PSA will no longer be used, and something else will come in that's more accurate?
I think PSA will still be used, but there will be some new markers that will be helpful in addition. I mean, like, for example, if you've had prostate cancer surgery, or radiation for that matter, the PSA is very, very helpful in following that to see if there's any recurrence of disease.
I like that minus 001.
Right,
That's my favorite number.
Me too.
Of all the numbers that I know. Dr. William Catlona, who you know about, he did a study on PSA. And this guy's probably rated as one of the best researchers on PSA and what it does.
Yeah,
and I want to talk about some of the things that he found in his study. A 75% reduction in metastatic disease at diagnosis, a 40% decrease in age-adjusted mortality rate during the PSA area, and 22,000 less men dying from prostate cancer than did in 1992, and the increase in aggressive prostate cancer increases with PSA level. If PSA is so bad as this government panel says, and less people are dying from it, what's the incidence rate? Are there more people getting prostate cancer today than got it, say, in 1992?
Again, that's a hard question to answer. We are definitely finding more prostate cancer than we did before 1990.
But he's saying that less men are dying than in 92. If that's the case, then there's got to be something good about PSA testing.
Yeah. But are less men dying from it because we're finding people that have prostate cancer where it really has no potential to shorten their life? And before that, we wouldn't have even found those people. So that's the question.
So it's chicken and egg thing.
Right. Or have there been people that have had surgery that we could have probably treated with active surveillance? That's the real question.
What is your position personally on PSA testing for the male population?
Well, like I say, I think a man should have a baseline PSA somewhere around 40, another one around 50, and I think between 50 and 70, he should have regular PSAs. I do believe that it does help people to live longer, to find and treat their prostate cancer if they have an aggressive cancer.
So the screening's reliable. I mean, the numbers are what they are. They're not necessarily, they could be a false reading in some cases, but they are what they are. Who should do this?
Well, first of all, let me just say there is a lot of controversy about this, and the people on this government panel are very, very smart people, and they're statistical sort of people. Dr. Catalona's points are well taken, but there are a lot of these statistics that show, if you look at people that have had problems with surgery or complications from their biopsy, and you take all that into account, you have to really balance this, and that's why it's important to have a judicious use of this. And I think there are some people that are 75 years old that maybe we used to do PSA testing on that really don't need it.
If I were today, I'm 78, and you would not test me.
If you came in and you were 78 and you just wanted to have a checkup. If your rectal exam was normal and you were peeing all right and everything, I would say you don't need
Okay.
a PSA.
Let's talk about the digital exam, the rectal exam, and I'd like you to talk about what guys are wusses. I'm telling you. I mean, I talk to guys about sigmoids and colonoscopies, and you think they were going to be put in front of a firing squad. But digital exam, you talk about that, and I've given talks, and I think, oh my God, a digital exam. Talk about a digital exam.
Well, I mean,
and
I think
why you need it, and you know.
It's the idea of it and thinking about it is probably worse than the reality. As you know, a prostate exam takes less than a minute. It's pretty quick. It's not fun, but I think it's worthwhile. Now again, a lot of these statistical analyses show, I mean, the rectal exam is not a perfect test, and it's subtle abnormalities, very small tumors, you can't find with a rectal exam.
Is any doctor qualified, any GP, any?
I think that most doctors learn how to do rectal exams in medical school. And rectal exams are important not just for the prostate, but for example, I saw a gentleman just this week that came in for a prostate check, a young guy, and he had a big rectal mass that turned out to be a polyp, you know. And
not good.
So I think rectal exam is an important part of just the
Had he had a colonoscopy?
physical exam. Have I?
No, him.
Oh, no, but I sent him for one.
Yeah, well, how old was he, may I ask?
He was like 50, I think, 51.
He should have had one before. Yeah. Talk about, you've got a digital exam, you get into the rectum, you examine, PSA comes back, and Dr. Alex Coper looks and he calls up the patient and then says, bring your wife, I'd like to talk to you if you're married. You come in, and but before that you do a biopsy. And I'd like you to talk about the biopsy, how reliable it is, what the technique is, and that's kind of the final step before making the decision on where to go from there. So yeah. I'd like you to talk about the biopsy.
Prostate biopsies are done by putting a needle, through the rectum into the prostate. When I was a medical student, or actually when I was a urology resident at UCLA, we did prostate biopsies by feeling a nodule with our finger and guiding the needle into the prostate with our finger. Now we do ultrasound, and we put an ultrasound probe into the rectum. It's about the size of a finger, and we can take pictures of the prostate. And then we use the ultrasound to guide a needle into the prostate. If we see a nodule or we see an abnormality on the ultrasound, we put the needle where that nodule or that abnormality is and take a biopsy.
So the ultrasound precedes the needle, so you don't have to do a bunch of needle jabs.
Right. And then we also do biopsies. If we don't see a nodule or don't see an abnormality, we do biopsies by a grid. We usually take biopsies on the outside surface of the prostate, at the front and the back and the middle. It's been shown that most cancers are at the front of the prostate or on the outside part of the prostate rather than in the middle. And so we have a little grid where we do the biopsies.
Biopsies have some risk.
Yes.
And I'd like you to talk about that.
So biopsy means sticking a needle through the rectum into the prostate, and there's really three things: bleeding, infection, and pain or discomfort. We do use a local anesthetic, and that does numb it and takes away a lot of the pain, but it's still a little bit uncomfortable. It's like, when you go to the dentist and you have the Novocaine shot, you still feel it, and so there is some discomfort.
But I tell people it's not nearly as uncomfortable as the bone cancer that you get when the prostate cancer metastasizes.
That's right.
Now that's uncomfortable. That is
right.
horrible. I've known two men that have had it, and it's not a pretty picture. So I'll take the needle anytime. I want to talk about and I'd like you to talk about, I should say, about the the combination of these tests, does that seem to be right now the best package available to men? The PSA test, the digital exam, and the biopsy. Put those three together and you get, is there a good, reasonable assumption that it's as good as you can do to today?
That is a very good thing to do. There seems to be emerging evidence about doing MRIs of the prostate, that you can actually see tumors better on an MRI than you can on ultrasound. And so some people we have get an MRI and it helps us direct the biopsy, or if they've had negative biopsies but their PSA is going up and we're going to repeat them, then MRI can help you know where to put the needle and where to do these biopsies.
So there's a lot of tools in your medical bag before you make that decision to say, and we'll talk about the different choices because it's like a Chinese dinner menu. Do you want number 7, number 42?
Right.
Anyway, what about the ethnic story of prostate cancer? How does ethnicity fit into this thing?
There seems to be some relationship between certain ethnic groups and prostate cancer. For example, African American men have a higher incidence of prostate cancer than Caucasian men. In Japan, there's a lower incidence of prostate cancer. But in Japanese people that live here in the United States, they come back up. And, it's felt that this is due to diet, like we talked about earlier.
Breast cancer is the same thing, almost unheard of in Japan until they started Americanizing, McDonald's killing America. They come over here, Japanese women come over here, and they're eventually, after 15 years, their incidence of breast cancer is the same as a woman born and raised in the United States. Diet, it's got to be part of it, and someday I think they'll pull the lid off of it. What about a man's family history as far as prostate cancer danger is concerned?
There are some genetic types of prostate cancer. In general, we talked about how prostate cancer increases with age. In general, the kind of prostate cancer that people get in their 70s, 80s, and 90s is not genetic. But the kind of prostate cancer that some men get in their 50s is genetic, and they have found certain genes that predispose men to have prostate cancer. So if a man has a first-degree relative, a father or a brother that's had prostate cancer at a young age, he's at much higher risk, and even an uncle or a grandparent.
Been diagnosed, Mr. Smith, I've got some bad news for you. And here are your choices. We can do nothing. You can get hormone treatments. You can get regular surgery, laparoscopic robotic surgery. We can implant seeds. We can do with radiation. We can freeze them. We can give you radiation in beams. We can give you vitamins. What is a man to do? I mean, the decision's tough. I mean, I went through this myself. And I opted for the laparoscopic robotic, but it is like a Chinese restaurant menu. I mean, there are a lot of things on there, and here's a guy that, until I have faced this, I knew about as much about prostate cancer as a dog, and then all of a sudden I became an expert for myself.
Right.
What's that all about? What do we do next?
It can be very confusing and it can be very difficult, and I don't think it's possible to find the answer on the internet. I think it really does help to have a conversation with your doctor.
What should lead a guy to say, I don't like radiation. I think, but then the surgeons surge and radiologists radiate, and there's some outfit down in Marina Del Rey that I think those guys are con men. But how does a guy make that decision? It's very difficult.
It is difficult. And, the ideal thing would be to take 100 guys and with the same type of PSA and Gleason score and line them up and say, okay, and go every other one. Okay, you have surgery, you have radiation, you have surgery, you have radiation, and then look at them 10 years later and see how they are.